Well, this is welcome everyone. With the start of this year, we actually have expanded to 4 days, so you see that we are doing few good things. We have changed the linings, say the artistic work for inside of this auditorium, and secondly, I'm sure I don't know whether anybody else. I think we are competing with Alaska. So cold inside. Let's hope. With that note, with a beautiful presentation by Beth, and that is where we are nowadays. That key is that you may do things, but are you doing with the guidelines and you are doing it correctly? And we all have our own way to do things, but and also I say there are more than one way to do the things, and this it has to be incorporated in our day-to-day practice. This Nurse Tech Symposium, and we started back in 1998, has been the integral part of this symposium, and of course Beth along with Antonio Tolentino has been instrumental putting all the contents together, and that everybody is ready to present and give you the meaningful information which you can take back and use in your practice to become better in one way or other. What I do usually is, for the year before of the year of the symposium, that is 2013, for our June here 2014 symposium, give the important advances in interventional cardiology. And the purpose there is that how we are changing the field to become better. And this goes with the Andreas Grunsvik, which wanted a catheter-based percutaneous treatment in vascular disease in awake and alert patients. And many of you know now that more than 50% of interventions, patients go home same day. After 5-6 hours, sometimes it is maybe not be good for the hospital, but that's the way it is. That procedures have become so safe and predictable that patients can be discharged safely, and of course they have a very good long-term outcome. The data which I'm going to provide, those top 10 advances, comes from various presentations, the articles which are calendar marked for 2013. Paper may be presented later on, but if it was presented in the scientific meeting, makes it to. And as I mentioned, purpose is to change in the clinical practice. The first one is the orbital atherectomy. You say, what is orbital atherectomy? Calcific lesion, which are the tough lesion to treat, because you try to put a stent, would not expand or may not go. So what we do is we do a rotablation, which is introduced in 1993. One of the device has been there for 20 plus years. Until now, we have nothing else addition to rotational atherectomy, which is a little complex, great device. Mount Sinai has made its name with the rotational atherectomy, but there was no new addition or no new advances in this field until last year. The new device came called orbital atherectomy. Now, what is the orbital atherectomy different than rotablation? There's not only work goes longitudinally on the wire, but also vertically in the space. That's the word orbit comes. And idea is that you make a bigger speed, you get a bigger lumen and ablation of the plaque. And this is the class, the cartoon demonstration. We were the first one to do the case on October 23rd of 2013, and the data came from the Orbital 2 trial, showing that it device very effective and low complication, and being used now commonly in the cath lab for this heavily calcific lesions. And that is the purpose, that you are using it only for the heavily calcific lesion. Very easy setup, less complications, less slow flow, and you don't need a separate nitrogen tank, and really giving a good results. Follow-up of the Orbit 2 trial, non-QMI was 9.5%, which is not unusual, with a real complication of death and TVR in less than 1%. Now we have 1 year data that overall the complication rate of the death, MI or TVR, about 16%. Comparable data 1 year follow-up in these calcific lesion by other trial have been up to 25 to 26%. So clearly, in my opinion, it's a great device addition to our treatment of calcific lesion. Then there are a lot of being done in the STEMI the field of STEMI, and then of course Dr. Keeney will be presenting. What we learned overall, that we need to decrease the door to balloon time. Once you get to 90 minutes, you really decrease the mortality, and that has become gold standard. And what has been seen, that now that 92% in the United States, patients have door to balloon time of less than 90 minutes. So clearly we have achieved our goal of decreasing the door to balloon time as a nation. Not as a region, not as a center, entire. Why? Because there is also the penalty that if you don't make it to 90% of the door to balloon time of 90 minutes in 90% of your cases, hospitals are penalized. It's one of the important parameters which is available on the website, CMS reportable outcome. So everybody has gathered and created their system, and only question came is that you brought it down to less than 90 minutes, but does it make sense? And it turns out to be that we have some data to kind of be a little sober in this whole concept. Now see the door to balloon time here, we have decreased from 83 to 67. As I said, 90+% are less than 90 minutes. But look at the mortality. From 2005 to 2009, did not change. You say, then why we are killing ourselves to make it door to balloon of 90? It basically tells you that you have to have a system in place. Some cases even go beyond 90 minutes. You are not being, it's 91 minutes. It doesn't happen that 89 minute you do PCI, patient survive, and 91 minute patient dies. It doesn't. So it basically is the concept that you need to have a system in place. So therefore overall PCI outcome of the STEMI patients have improved with the result that whether you decrease the time or so, further it does not make a difference. And they actually have seen even in the, once you have more than 90 minutes, you do get little uptick of the mortality. So clearly you need to bring it to a less than 90 minutes and so. And the same data with the 30-day, those are in hospital 30-day, same, that very little difference in terms of various mortality. So therefore, what basically is that now we need to go beyond door to balloon time. How can we decrease this mortality even further? And that's where the whole concept is the PCI technique for epicardial thrombus removal in the vessel, or adjunct therapies to increase microvascular perfusion by using newer devices and better therapy. One of them is removal of the thrombus by aspiration catheter. TASTE trial, which showed in the past, was very useful, but the recent data of the 4,000 plus cases did show some benefit, but was not statistically significant, but there was associated lower stent thrombosis. So many people believed before the TASTE trial, which is a major trial of, as you can see here, we are talking about 7,000+ patients, showing that thrombus aspiration overall did not make a difference in mortality and TVR, but did make a difference in the re-MI and stent thrombosis. So what you do, you don't need to use in every case. When there is a thrombus, use an aspiration catheter. Then this is a study led by Dr. Valentin Fuster, giving a beta blocker, which is a very cheap agent, intravenous metoprolol in the in the ambulance or before patient come to the cath lab, showed that there is a reduction in the myocardial infarct size. So it means you improve the myocardium overall salvage by using the intravenous metoprolol before patient hit to the hospital, either in the ER or from the ambulance. So clearly, simple, cheap way, you decrease the overall myocardial infarct size. What does that mean? It translates into better mortality, better improvement, better survival, less arrhythmia, less CHF at follow-up. And they presented the data of the 6 month in ACC, which is consistent, that patients who receive metoprolol had a significantly lower incidence of arrhythmia and heart failure at 6 months. But just to say, salvage myocardium with a simple test, simple medicine of metoprolol. There is other data they have given the Angiomax in the ambulances, and it showed that there was little benefit of lower bleeding, although there was slightly higher stent thrombosis, so it probably won't go further. But clearly the beta blocker will become a standard. People always ask, you have a STEMI, should you put a drug-eluting stent or the bare metal stent? And actually, because people are worried that maybe in STEMI you have a higher stent thrombosis with the DES, and we have the data of the 3-year data of the Horizons AMI trial, even with the old generation Texas stent, that there is no increase in stent thrombosis, while with the newer generation, which is the Zions, you can see lower stent thrombosis versus bare metal stent. So clearly, there is also meta-analysis that even in STEMI patients, if possible, use the drug-eluting stent, not the bare metal stent, because you do better by using a drug-eluting, less complication and less stent thrombosis. There is another trial which will be evaluating various of these combinations in the future. Then the mitral clip, mitral valve regurgitation. So question is that can you clip non-surgically this leaky valve? Mitral regurgitation, the surgery is very effective. Dr. Adams, the pioneer and leader of the mitral valve repair at Mount Sinai and of course national and worldwide. The very simple, easy, dependable procedure. But some patients are again non-surgical. Surgeons say, well, too high risk, we don't want to do it. So question is, can you do something in those cases? And what has shown that putting a clip by puncturing from the, coming from the right atrium, left atrium, and then you put a clip into the ventricle and bring these leaflets together. This actually started with the Alfieri concept that you just bring the leaky valves leaflets together, so you decrease the regurgitant orifice from this one to two small ones. And this actually has shown, like this is the typical case, this is the LV-gram and this is the regurgitation. You see here the whole left atrium is filling, and now after the clip, decrease in regurgitation. This is the clip. So this clearly has gone through the Average 2 trial, which showed that it's safe. Although efficacy point of view, the clip was inferior to mitral valve repair. But again, in the cases, these are high-risk patients, and we have the data up to 4 years, that overall, that some patients, 20% of patients require mitral valve surgery after the clip. But overall, in inoperable cases, good device to use rather than just continue medical therapy. And actually it has been approved now for a high-risk degenerative mitral regurgitation, and patient with a functional MR, ongoing trial co-opt, which will randomize patient to mitral clip to the control group to see patients with a moderate to severe MR with LV dysfunction. They keep coming back to the hospital. They are on optimal medical therapy. They already got BIV AICD. By putting a clip, would you prevent their readmission and survival? So this trial is ongoing. Then we actually have many the stents for the bifurcation, but first time in the United States, the Triton stent, dedicated bifurcation stent, which have a very kind of spring-like design into the main vessel, but the stent of the side branch, and then you put a DES in the main vessel, compared to your regular technique, which was the Triton bifurcation study of about 700 patients, showed the failure of the Triton stent compared to a regular treatment. And what is regular treatment? You do a balloon of the side branch. If necessary, you may put a stent in about 10-15% of cases, rather than putting a stent of the Triton type, which is a bare metal, in all patients. And you can see here, it led to, particularly because of the higher myocardial infarction. So the trial was negative, and there was no slightly higher stent thrombosis, but was not statistically significant. And yes, you do improve the lumen, but without any use. So that FDA actually has not approved this bifurcation stent, and the whole concept, whether you put a one stent or two stent in the bifurcation, with which technique we have favored the simultaneous kissing stent technique, SKS, although many others are being used. And it actually shows that in a large bifurcation, you use two stent or one stent technique. It seems to be that using a two stent technique may be associated with a slightly better outcome. There is one trial called DK Crush. It's a very technically challenging, but it's basically the two stent approach compared with a single stent, and showed actually two stent approach is superior to the single stent approach. And this is the green is the two stent, and orange is the one stent approach. So seems to be the field of bifurcation still remain with the optimal interventional technique, and there is no dedicated bifurcation stent at present. Now then, issue about the radial intervention. Remember, the radial really has come to now United States, compared being outside. Few years ago, the radial intervention was in 2 to 3% range in 2007-2008. And now it's about 16% as of 2012. The latest data of the 2013 is about 21%. 21% intervention in the United States are being done with a radial approach, compared to many other places outside US, in India, in France, in many places, the radial intervention makes up to 70% of cases. So it's still, but adoption is there because of some questionable trials, not so good, and so that really the radial intervention is not caught up to that extent in the United States. There are many centers, many interventionalists who do their majority of cases as a radial, but overall it's still about 20% here. Now then question was that there was a major trial called SAFE PCI, that is the patients undergoing cardiac cath or possible PCI that randomized to radial or femoral, thinking that in female, because they are associated with higher bleeding, and we know the vascular complications are higher in female, maybe the radial is a better approach in those cases, and those were the primary endpoint. Efficacy endpoint in terms of bleeding, and the feasibility endpoint with the site crossover, and other usual endpoints of the radiation dose and so. And now what basically we found in these patients, actually the trial, they stopped it little early, felt that will be no benefit, and basically came out that as far as you talk about the primary efficacy and the feasibility, the bleeding was lower with the radial in the women, but crossover was 6.7 versus 1.9, so that one primary endpoint was met, other primary endpoint was lost. So clearly this was a mixed result of the SAFE PCI, and then you go to other point, those who had a particularly intervention PCI cohort, they actually you see there's not much difference in bleeding, and of course significant difference in crossover. So it's all depends how you want to interpret the data. Some people who are believers of radial say, you see, we have actually trend towards lower bleeding, may not be significant, but trend towards in women. But the other side, many of people say that, why? It didn't show any benefit. And actually overall, the MACE rate, you see the procedure duration, total radiation exposure, the contrast volume, and the 30-day event rate, particularly slightly higher, as you can see on the radial side compared to femoral side. So we didn't get any final answer. So, and that is why it shows that radial has not really taken off in United States. Then there were a few other studies done. Particularly, this is actually again the data from our NCAC-DR, that radial interventions continue to increase, and showing that in STEMI patients, radial is associated with lower mortality. There are a few trials, those who attended last year's symposium, the rifle stacks trial, and the two others all showed that there is a lower mortality in patients with a radial PCI in STEMI patients. But, and same also from the registry, there seems to be that in STEMI patients, radial is the good approach. Now what about the bypass? There is a trial called radial CABG trial, which was done and showed that radial access versus femoral, that you see in every point, radial lost. So if you have a bypass surgery, radial approach is not a right thing, because it's more fluoroscopic time, more contrast volume, and so on and so forth, whether it's a PCI or just diagnostic cath. These are the various groups. TR group in the radial versus transfemoral, you can see, except that patients preferred, once you do a radial, they preferred, although more radiation, more contrast volume, but it's the ease of use for patient can sit up. So the patient did have an excess preference for the future cath if you do a radial, but in my opinion, radial CABG that tells us that CABG patients should not be done radial intervention. Now therefore, that's the way I put it, that what has been shown, that really that the transradial PCI recommendation, my opinion, that increasing the TRI volume, that we know there is no benefit or harm in the CABG patients. Radial spasm may be fistula, aortic arch anomaly, very difficult to do a radial. Then benefit is in decreasing the bleeding or vascular complication, particularly high risk bleeding, overweight, PAD, questionable women. Routinely may or may not, but those are the group, you'll decrease the bleeding. But you'll decrease the bleeding as well as you decrease the MACE and mortality in STEMI and ACS. So clearly the question comes, it's a very challenging patient subset, so you need to have a practice to get there. So clearly everybody should be proficient in doing a radial intervention in this day and age, although the use may be by the guidelines could be a class 1 in STEMI patients, but everybody else you just may do it in appropriate cases to decrease the bleeding. So then the question about the depth duration, we know that we give for 1 year of antiplatelet therapy routine. If need to be interrupted, we give a bare metal stent, and there many trials have done. Maybe can we decrease the duration to either 6 months or 12 months, 6 months or 3 months, and as you can see here that MACE outcome were identical whether you are a short term or long term. Rather, with the lower duration, you have a lower bleeding. So seems to be that the short duration is fine. And there is another trial called Optimize, similar message, 3 months versus 12 months. You can see every point, every aspect of the event is identical, 3 versus 12. So clearly you can reduce by 3. There's another trial called Arctic. They say, well, after 1 year, should you continue for additional 6 to 12 months of antiplatelet therapy, particularly clopidogrel? And they found that after 1 year, you're continuing only aspirin or aspirin clopidogrel, again, no benefit. So seems to be the 1 year is the maximum, maybe even go down to a 3 to 6 months and so. And therefore, I would say depth of 6 months, maybe 3 months in some cases, is the new 12 months which we used to do routinely. And the whole question comes, studies also have shown that if you stop after 6 months and patient goes for surgery, you don't penalize with higher stent thrombosis. But another major trial published by Roxana Mehran is the Paris study. And just to see the pattern, that after DES, follow these patients and see what happens to them. And basically, she classified the depth cessation in 3 categories. One is the discontinuation. That patient had discontinued depth as per MD's recommendation. Why? Because patient has a bleeding. Appropriately, you stop it. Second is interrupt, because patient needs surgery under physician preference, and then you restart within 1 to 2 weeks. Or last one was disruption, that you stop it completely, patient stopped it, or ignorant physician stopped the antiplatelet therapy in these large number of cases. And basically you can see that if you have the discontinuation versus disruption and interruption, that discontinuation is the most overall discontinuation occurs in 40.8% of cases at 2-year follow-up with a 57.3. But more important message came out from the study is that your MACE is related with your interruption or disruption. That you can see here that if you have the hazard ratio that on depth is 1, that if you discontinue under the physician preference, you do not penalize. This is a very important message compared to disruption. And you can see if you disrupt very early, you have a very high incidence of MACE as well as stent thrombosis. So seems to be the short discontinuation or interruption is okay, but not the disruption, and these patients need to continue. There is another major study which will be presented in AHA this year to answer with a depth study in large number of cases. Then we have now many DES stents, and of course Antoinette will speak about it. The whole concept is going with the thinner struts, thinner polymer, and the bioabsorbable stent, and the basically thin struts. And now the studies have done with the various stents and stents trial seems to be that they are equally effective. There may be a slightly lower stent thrombosis with the Zions stent, but as far as efficacy and restenosis are identical. Now also, what has been another concept is what about polymer-free stent, the durable polymer versus biodegradable polymer, because you don't need the polymer or drug after 6-9 months. And it has been shown that if you remove that polymer, that after your 1 year, very low stent thrombosis. So clearly the field is going on that field. In the stent designs that get a thinner or bioabsorbable polymer, so the lower late event. Same thing happened with the Zions USA. And as I mentioned, that in various studies of the stent comparison, cobalt chromium of the Zions comes superior. And of course, the bioabsorbable stent, the field is ongoing. One which we have approved outside the US and has done the trials of the bioabsorbable BVS, showing very excellent results, although a small number of patients, but no stent thrombosis. And the purpose basically is that the vessel, after the stent is absorbed in 2 to 3 years, it behaves like a normal vessel. It's not cased by the metal now. It will have a constriction, dilatation to the physiological stimuli, and that is the biggest benefit. And the Absorb 3 trial, which has completed now, and which randomized 2-to-1 to Absorb versus Zions, and the data will be presented in next year in ACC to really see where the Absorb stent will fit in. Now, Syntax trial, remember Syntax trial was the multi-vessel disease patients based on the Syntax score, came up with the numbers of the low Syntax score of 22, intermediate 23 to 32, and high more than 32, and basically showed that there is a gradient when you have a low risk versus low score, intermediate and high risk, CABG versus Texas, low score, CABG and PCI in the death, CV, AMI, and revascularization about equal, although clearly PCI has a higher revascularization. You go to intermediate risk, you start having now little higher myocardial infarction with PCI, although no significant difference in mortality. You go to a larger risk, high risk score, now actually there is a higher mortality in the PCI group. So that actually has led to our understanding that high syntax score means multivessel disease, multiple lesions, they will do better with the bypass surgery compared to PCI. And this is what we have changed at Mount Sinai. CABG here, PCI orange, and medical therapy in this high syntax risk score. You can see here proportion of patients more at present are going to the CABG compared to a PCI in the past time. So clearly it seems to be that more and more patients are being referred for the high syntax score for CABG, which is the guideline appropriate. There is a major trial for the left main, particularly Excel, has completed enrollment a few months ago. They've actually stopped trial at 1,800 patients. The data will be at least 2 years away to see if there is a difference in a Zions versus CABG in left main patients. Then we go to the CoreValve extreme risk aortic stenosis group. We actually now have 2 valves which is approved by FDA. This is our Edward Sapien, which is based on the partner trial. And as you know, the valve, basically the disease aortic valve, we dilate with a balloon and implant the valve. Valve stays there. And of course, the second valve is the CoreValve. This is balloon expandable, and it's a self-expanding. And I know Melissa will be talking later about all this trial designs and so, but it's a very simple, in high-risk patient with pace ventricle at 180 beats per minute, so the valve does not move, and instantaneously you're taken care of the gradient, no regurgitation, and has become second valve is the CoreValve, which is a self-expanding, again with the same technique, percutaneously you advance them without any surgery. About 20% patients still require, because femorals are not good enough, you require either surgical exploration or a direct aortic access from the right part of the sternum, some cases done as a transapically, and after you confirm the position with another pigtail catheter, and then you release the valve, and valve stays in position. People always ask why the valve stays, doesn't embolize, because the calcific aortic valve keeps the valve in position, and it works right away, decrease the gradient, decrease the regurgitation, and many of these patients can go home within 2 to 3 days. So really this technique has come to the final with the improvement in the overall compared to standard therapy. This was a partner trial that clearly that you decrease the mortality and rehospitalization by using the valve. Second, the CoreValve, the extreme risk and the high risk. Extreme risk were presented last year in TCT by POPMA, and the high risk was presented by Dr. Adams this year in ACC. Basically what did it show? That overall mortality using these valves is about 17 to 24%, whether you call cardiovascular or all cause, and very low risk of stroke. So seems to be the CoreValve is the valve which is first time has shown lower CV rate than comparative historical control, or in the high risk group trial lower than surgical AVR. So clearly good device, and this is what we use and has shown the lower stroke rate. People do ask, do we have a long-term data of the percutaneous valve? We actually have the data of the small series of patients up to 5-year outcome, and it shows basically that this is the improvement in the aortic valve area, this is the decrease in gradient, that you do lose a little bit at 5-year follow-up, but sign of moderate prosthetic valve failure occurs in 3.4% of cases. So clearly that very durable, similar to our percutaneous, bioprosthetic surgical valve. And these are the data at Mount Sinai, where we use both CoreValve and Edward Sapien, compare with partner trial, excellent results, 77% transfemoral, 18% direct aortic access, rarely apical, and so. So last one is the PREMI trial, and you say what is PREMI trial? Is the prophylactic PCI in STEMI, that we know when you do a non-culprit vessel PCI, in the studies have shown that you do a non-culprit vessel, you have a higher complication rate, But now there was a first time major randomized trial done to see that whether you should do a preventive PCI of the non-culprit vessel on top of the culprit vessel versus no preventive PCI. And you see preventive PCI had a lower cardiac death, MI, angina, death and mortality. So seems to be a good concept to do a preventive PCI in a suitable lesion at the time of STEMI, although it is going to go through various analysis with the newer trials before we make a recommendation. So these are the top 10 advances, in my opinion, which have changed our practice with the TRI, Doortoballoon time and Triton negative, with the mitral clips, Zions, BVS and DAP up. Pre-hospital treatment and the syntax scoring really make a very big difference to become better interventionalists, and overall PCI numbers have gone down, which is consistent with the overall here also 5% decrease at Mount Sinai of 2013 compared to year before, growth in endovascular and the TAVR procedures, and that consistent with in the New York State. You see in the New York State, there is about 15% decline in the PCI volume in 2012-2013, rightly because of the appropriate use and the appropriate medical therapy. And more important is that whatever you do the best. And this is actually just sum up our latest 2009 to 2011 data of top 10 centers, and you get double star means your risk adjusted mortality is lower than statewide average, and you clearly see that highest volume, but more importantly the two categories having a double star. And this is actually for last, I took only, present only 5 reports, and you can see here that every year when report comes that Mount Sinai gets double star in one or more categories or by the physicians. And just to this exemplify the uniform use of the protocol, following the guidelines, and incorporate all the newer advances which are coming rapidly, and then develop your own experience and algorithm. And I welcome all of you. Thank you very much, and hopefully it will be exciting for the next few days.